Good afternoon. My name is James Earlham. I'm Deputy Director of the Primary Healthcare Directorate, and we're here as part of the Primary Healthcare 40 commemoration program, a series of cross-disciplinary seminars and workshops and talks over the next 6 weeks to remember the 40 years since the International Declaration on Primary Healthcare at the Alma Ata Conference. It's been 40 years of some progress and some regress in primary healthcare. And as a faculty, we have adopted the primary healthcare as the lead theme to guide our teaching and research and service. And so the purpose of this Primary Healthcare 40 program is to bring together different disciplines to look at what we are doing as a faculty in realizing the vision of primary healthcare, how we could be doing better, and to be inspired by what is happening. And so this afternoon we're pleased to welcome the student leaders from SHAWCO, who are here to tell us about the 750-kilometer trip that they have done as part of the 75-year anniversary of SHAWCO. We're here to remember and honor our late Dean, Professor Bongani Mayosi, as well, whose words on the screen behind me remind us that our future is guaranteed by the quality and vision of the leaders that we leave behind as our legacy. And so the leaders within SHAWCO are a wonderful example of that. And so I'd like to welcome them now to the podium. Thank you.
Good afternoon, everyone. My name is James van Duren, and I'm the current Health Sector President for SHAWCO. First, thank you very much to the PhD Directorate and all involved in the PhD at 40 celebrations for inviting us. Today, we're just going to present a little bit about what makes the SHAWCO model something that we believe is successful in South Africa and in the world as a whole. A model that we think can be emulated, and a model that we think really helps to contribute to improving healthcare at the primary care level in and around Cape Town. SHAWCO was founded in 1943 by Andrew Kinnear, who was a medical student at UCT, as well as Prof. Golda Seltzer. He worked in his holidays as an ambulance driver to try and pay for his studies, driving in and around Kensington, what was then called the Windermere area. And he identified a need for quality primary healthcare services to communities in need. Together with Dr. Seltzer, who was a lecturer in the pathology department, they looked into establishing a student-run clinic, and SHAWCO was born. SHAWCO grew quickly in the 40s and early 50s to include sites in Kensington, Elsie's River, and elsewhere, and forged a strong relationship with UCT, RAG, which is now a major beneficiary, and the Cape Town communities where we are based. Here's just two quick photos that I found. On your left is Andrew Kinnear, and on your right is Prof. Golda Seltzer. I also found some images of the early days of SHAWCO's clinics. On the left is one of the first mobile clinics that was ever run by SHAWCO, and some medical students there on the right. And then this is a very interesting photo because this is the SHAWCO Kensington Centre. It was one of the first SHAWCO centres, and the line outside, as you can see, is quite enormous, just showing the demand for SHAWCO in the early days. Today, SHAWCO has grown from what was activist beginnings during the apartheid era to become one of the largest African student-run volunteer organizations. We're the largest student society at UCT. In 2001, Mrs. Grasser-Michel was selected as the Honorary Life President. And SHAWCO has expanded from just running free primary healthcare clinics in our health sector to education sectors, academic interventions, Saturday school, international division, and transport, etc. All of them really working together towards SHAWCO's missions and vision. Adapting with the changing times is something that's very important for us. And in 1994, SHAWCO, with the new democracy we were experiencing, adapted from what was a welfare model to one focused on upliftment and development. The SHAWCO mission is to work together towards informed, healthy, and thriving communities. And I hope that we'll show that this is something that drives all of our interventions. Today, our health sector operates free primary healthcare clinics at more than 10 sites across the Cape Town metropole, catering to nearly 4,000 patients a year. This includes specialized pediatric clinics, women's health clinics, and health rehabilitation services. Clinics are organized and operated by teams of medical and H&R students under volunteer clinical supervisors, and we reach at least 750 distinct UCD student volunteers annually. We also have student-led student leadership covering 15 portfolios of student development, women's health, mental health, international, rural health, etc. The real aim behind this is to provide space for students to lead in healthcare and to also encourage a comprehensive and holistic approach. We believe that our main benefit is not just to the students, but also to the community. This year is also SHAWCO's 75th anniversary, which I think is a great tie-in. It's the 40th anniversary of the Declaration of Alma Ata. SHAWCO turns 75, and an interesting point is that WHO is only 70 years old, so SHAWCO was around 5 years before them. I'm going to invite Liam to come up. One of the big projects we had at the beginning of this year, and we're really excited to present some feedback on, was our 750 kilometers for SHAWCO trip, which we did earlier in this year, taking all of our SHAWCO operations on the road to reach communities in need.
Good afternoon, everybody. My name is Liam Devenish, and I'm the current head of clinics for SHAWCO Health. So I'm going to be speaking briefly about the 750 kilometers event, which was hosted, as James said, from the 3rd to the 7th of May earlier this year. And the idea was, as James has mentioned previously, is meeting patients where they find themselves, and we wanted to do that in the broader context of the Western Cape. So just to begin with, just a brief overview, we're going to contextualize why we did it, what exactly we did, and then who we took with us. So to begin with, as James said, it's our 75th anniversary, and a big question that was on everybody's minds in the last little while is how do we memorialize SHAWCO? So in order to sort of look into this, I decided I would go to the original Alma Ata Declaration and see exactly what it says about primary healthcare and what is imposed upon us as students and as healthcare workers to do. So first of all, we need to address existing gross inequality in health. That people have the right to participate individually and actively in their healthcare, and that's something that we try to keep central to our services. And then next, of course, that health permits them to lead socially and economically viable and important lives. And that's something that we really try to emphasize on the trip, especially given the community that we serve in being so leading such difficult lives because of the occupations that they're involved in. And then finally, it requires action. So what started as how do we memorialize SHAWCO, I think morphed into something rather of how do we espouse the objectives of primary healthcare in a manner that memorializes the legacy of SHAWCO in a way that SHAWCO does it, so a model of healthcare that SHAWCO can present. So what we came up with was perhaps the 750 kilometers for SHAWCO event. And what we sort of defined it as our political atmosphere in South Africa has changed, and as things have progressed, that we no longer have the political sphere of apartheid, but rather have structural difficulties that reduce healthcare access for our communities. So things that we need to look at is how do we strive to present an integrative platform that addresses the community deficits as we see them now, and create not just healthy communities, but healthy and striving ecosystems that can benefit people in every sense. And so we were called to reflect, look inwards and outwards to see how we can broaden this concept of community to not just Cape Town and the 12 communities that we serve on a weekly basis, but rather perhaps the whole of the Western Cape and how they might benefit from our services. And so we took it to the Western Cape. So in general, the way that we did this was we tried to present a microcosm of what a high throughput, I suppose, primary healthcare platform could look like. So as James mentioned, the model that we used was a mobile model where we took all three of our mobiles, our BP, KTC, and Big Mama, which is a massive vehicle, and we traveled throughout the Western Cape. And what started at 750 kilometers, in part due to my poor planning, in part due to my underestimation of how big the Western Cape is, turned into an over 1,200 kilometer trip with some 8 to 9 hour bus journeys in between, providing clinics for up to 200 people a day. So in total, we had 6 vehicles, 56 people, and we saw over 600 patients in 4 different communities around the Western Cape that were identified by our partners, the Trust for Community Outreach and Education. And over here you can see we're in an array of different places, most of them very beautiful, sometimes in schools, sometimes literally on the side of the field in a side of a farm in Clan William on an open field, which presented problems of itself. And then an extremely isolated hamlet of Zawar, all the way past Ladysmith in the Western Cape. So what we try to do, as I said, is we try to look at how we can take SHAWCO and use it as a model of what primary healthcare could look like in its most integrated and comprehensive sense. And the idea would be that before a patient even saw a clinician or saw an occupational therapist, that they were able to access resources, that they were given comprehensive, I would say exhaustive, but comprehensive, a wide-ranging health education, as well as being screened for non-communicable diseases that we thought were important. So the first thing that we did, just to walk you through it, is we devised this patient flow model, which had to be adjusted a little bit after our first day when we realized that things weren't quite as easy as it seems. You can't just have something on paper and then put it on the door and then everybody does it. So to begin with, we would have patients arrive, we'd have 15 to 20 patients moving through stations at a time, and the idea was sort of to billet patients slowly to our cubicles, because we only had between 1 and 2 doctors. One day we had 4, but about 2 doctors a day, and a couple of occupational therapy students and a dentist with us. So to see that volume of patients in the level of care that we would like to provide is quite a challenge. So I think we rose to the challenge in most accounts. We were extremely inundated on our first day, but it made for good stories. So after that, patients would then advance to 4, it only has 3 here, but 4 different health promotion stations that were identified with by TCOE and ourselves. So non-communicable diseases spanning diabetes and hypertension, communicable diseases spanning HIV and tuberculosis, then fetal alcohol spectrum disorder and healthy pregnancies, because the communities that we were visiting have some of the highest prevalence of fetal alcohol spectrum disorder in the world. And then fourthly, family planning. And this was the first time that we had a family planning service and an STI treatment service that was rolled out at SHAWCO, so that was very exciting. And this was done in a very sort of integrative manner, or encompassing, that's not the right word, but a very interactive manner rather, by various students who would rotate through the 4 different disciplines that we hosted during the weekend. So one group would be on health promotion and clinic administration, another group on women's health, another group on pediatrics, another group on adult health. Then clinic administration, what we thought is it's important to, even at a primary healthcare level, triage patients, as it were. So is a patient sick today? Do they need to see a clinician or an OT today? If not, can they be given screening, resources, have question answers, and sent on their way? And in that way, we delineated how we could best apply our clinical services in an equitable manner. So we did that. We had little color coding stickers, and we had patients moving through in all different directions. And it was really fun to see how students, even at the 2nd or 1st year level, were able to take a clinical picture and integrate it to be to teach themselves how to be a manager of a clinical situation in a way that was responsive and effective. So then patients would move on to screening, and we had from 2nd years to 6th years doing screening, basic just blood pressure and glucose, and if it was a female who was of reproductive age, occasionally we do hemoglobin, although that would often happen in the women's health sector. And then if we picked up a problem, we would immediately write referrals, because we obviously can't manage chronic conditions, and then they would be shuttled to the various divisions of where they would be receiving care. On some days, we set up specified HIV clinics, as well as implement HIV cubicles, implement cubicles, and pap smear cubicles according to what was needed. So again, a very receptive sort of way of organizing healthcare that relied on a student team that was able to respond to the changes as they were happening and as we had patients flowing in and flowing out. Then if the patient did need to be seen, they would then move on to clinical management or be referred internally to an OT. They would then see the pharmacy, have their questions answered, and then leave. And in this way, we were able to see up to 200 patients a day with only 2 doctors, and all of these patients received resources, education, screening, and were able to see a doctor or an OT if necessary, receive the referrals and the medication required. And this is something that we would like to look into rolling out all of our clinics perhaps, or having pop-up clinics that follow a similar model where we can not just focus on getting as many patients through at a time, but rather making sure that we are meeting exactly what the patient needs at that time in a way that's discursive and is based on what the patient thinks they need as well. Another thing that we obviously was identified specifically by TCOE, our partners, was that it's all good and well to take a primary healthcare service to an area, provide a clinic that's comprehensive, provides education, etc., but then leave the next day. It leaves a massive gap where it might not have been better to provide the service in the first place if you don't somehow leave something engraved in the community. And I think we achieved this to a certain extent, so it's something that we'd like to work on. So one way we did that was through health education and resource provision. And another way was through the upskilling, what we called community health liaisons. So I have a couple of booklets here if you'd like to hand them out, just flip through them while I'm talking about it. And what we did is, together with our student development and health promotion teams, we devised what we called just a brief guide to community care and screening for women mostly who are identified in the communities that we saw. And what we did is we hosted an informal skills session where we could train them up in, first of all, embedding themselves in the community as somebody who is empowered and educated according to what is needed for a community's health. then to enable them to visually screen people, see if people are sick, keep tabs on their communities as a normal CHW would do, and then lastly provide information to an extent that they are able, and then refer people if necessary to where there is healthcare. And this was sort of done with the idea of creating what TCOE termed safe centers, where you would have people who are embedded in the communities, as I said, who are seen as integral members who are able to shuttle people to the health services as required, as well as provide information in a safe place for people to contact them if they're having any health-related needs. So specifically with things like intimate partner violence, structural issues related to healthcare. When we were having these sessions with women in Swellendam and Zawar, a lot that came up was structural issues and political issues actually, and of course we don't have agency to change that as a student organization based in Cape Town, but it was an encouraging conversation to be able to give people some form of knowledge and agency and empower them in the sense that once we were gone, they felt that they could rally themselves around a cause for healthcare. And we haven't been able to assess to what extent that was successful yet, but it is something that we are wanting to grow and move forward in. So those are just a couple of the things that we rolled out at this clinic, and overall, I think we were largely successful. We did, obviously there were some hiccups in the road, not a small one being how very far we traveled and how difficult it is to provide hands-on clinics using only a finite number of resources and a finite number of students. But in total, we were very chuffed with what we were able to achieve. So our best counts estimate that we saw over 600 patients over the 4 days, with 4 strands of language-appropriate needs and burden-based healthcare promotion. And every student was able to rotate through the 4 different sectors, as I said. So after that, a good proportion of the students were able to so a good proportion, I would say up to a third, and received prescription medication, intramuscular injections, bedside testing, specified health education, IPV and mental health screening where appropriate, and then referral to OTs. And they were a massive resource that we hadn't even considered how useful they would actually be necessarily, because we've never integrated them in our clinical, well not never, but we haven't yet integrated them in a clinical service. And that was an eye-opener for us that perhaps medicine and occupational therapy should be integrated even at the primary healthcare level in a student-run organization. So that was very encouraging. And then over 50 women were given elective pap smears. It saw the rollout of our family planning and STI treatment program. We managed to screen an entire school for fetal alcohol syndrome and developmental disorders in Rawsonville, which was again very encouraging and a massive outlay of this that we hadn't necessarily anticipated. And then finally, 50 health sciences students were able to interact with high-level clinicians across the board, learn how to manage a clinical practice their clinical skills, as well as their engagement with communities on various levels depending on which area they were stationed in for the day. Can we necessarily equate the benefit of service outlay, and how do we gauge the community relevance is a bit more of a difficult question that we are going to have to think about how we answer it. And if we do something like this again, we will have to incorporate some sort of monitoring evaluation. But I think at least in the sense that patients were able to tell their stories and students were able to listen, if that is the only thing that we're able to get from this, which I don't think it was, then I still think that's something positive. So if we have a moment, we're going to play a video that has been made by our wonderful marketing team. And if there are any questions while I'm setting that up,
I'm one of the group members on the trip, and today we're responsible for the admin station as well as health promotion and screening. So in terms of the admin, we see the patients, we triage them and find out why they're here, and then we'll send them to their respective clinics, so women's health, peds or adult health. And then we also have 4 health promotion stations, so we're doing non-communicable diseases, infectious diseases, family planning, and like healthy pregnancy and FAS. So yeah, that's what we're on today, and we're basically just waiting for the patients now.
And insulin is a chemical, it acts like a key. So it unlocks that little wall so that the sugar can float out of my blood into my
I've been working in the women's department, women's health, so we've been screening them, HB, glucose and all those things, and then what we're trying to promote is family planning. But I'm learning a lot how to manage things, how to delegate, how to use my colleagues to actually help me and work as a team. So you don't have to have your hands on all the pies because you have a lot of hands holding the pies, if that's an analogy. Yeah.
Hi, my name is Regan. I'm a second year medical student and this is our second day of the SHAWCO 750 kilometer trip here in Swellendam. I've just finished seeing my 4th patient for today and wow, like it's been really good. It's felt so great coming on a trip where I expected to be a part of a community, but now that I'm here it's actually being fulfilled. And I think that's where the beauty and the importance of this trip lies, is that we can come in and we can help and we can work together with the people that are already here. So what I was expecting from the trip was to like just come and learn a few things, help a few people, but what it's taught me is like the importance of primary healthcare and the ideologies around it that we've learned already but are now seeing in practice working, helping people, helping communities grow and develop. And I'm just really excited for tomorrow and the day afterwards to carry on doing what we're doing. Yeah.
We had the workshop and it was a very good workshop for us as youth, and we learned a lot as youth, and we can talk to our communities, we can go back to our communities and we can go learn them also about their health and how we must work at our health, because lots of our people are sick and we don't know how to handle the sickness because our clinics don't come out every time. So we have a problem in our communities with the health situation, and we can go back to our children and we can learn them to go back with their health.
Definitely ready for the 3rd day. What I'm feeling is a weird mixture of anxiety and hunger. I'm I'm also carrying 2 muffins and 2 absurdly small slices of toast. So...
How are we feeling, guys?
Thrilled. Keen.
Exhilarating and...
Enriching.
Calabunga.
Eager.
Opgewonden.
Rested.
Excited.
Today is day 3 and we're ready to go provide some healthcare.
Today, my name is Enrico Daniels. I'm from Menenberg in Cape Town. I grew up very poorly and now I find myself working for SHAWCO, which is a huge step in my life though. I come from the background where people is killing each other, fighting every day in front of me, and I find it very exciting getting myself out of a situation like that, coming here, enjoying what I do. They do care about the communities, going out there, working with poor kids, helping them with their health, and it motivates me though. Yeah.
Talking about my experience on the 750 Miles for SHAWCO campaign, on our first day we were in a farming district outside Clan William. We were based on a field and the patients came referred to us by and large by the farmers of the district who brought their farm workers. So we saw a fairly uniform group of patients who were all working people between the ages of maybe 25 and 55 and who'd been doing this work for many years. So we saw many musculoskeletal complaints, pain, body pain, knee pain, back pain, and they were mostly people who were in work. But who had very hard lives because of the type of work that they were doing. On day 2 and day 3 we were based in Swellendam at the school, and on day 3 in Zuar, and both of these are semi-urban areas. They also house many farm workers, but we saw a much wider range of patients. We saw many children, we saw many adults, we saw so many old people, and these people seem to be better serviced by their local clinic. Many of them do have clinic appointments, they are on chronic medication, and it was a different spectrum of disorders. We saw a much wider spectrum, from children with skin rashes, with respiratory conditions, with various things. We saw adults, a lot of adults with high blood pressure and with diabetes not controlled, and again many social issues, people who were out of work, people who had domestic problems. We saw some sexually transmitted diseases. It was a different range of conditions that we saw, and in Zuar perhaps a poorer socioeconomic group of people, right across the spectrum.
My name is Gavin Jokums. I'm the director at SHAWCO, the Students' Health and Welfare Centres organisation. We are based at the University of Cape Town, and here we have come to the end of an awesome 4-day program giving health services in our rural communities. So well done to all of our students for an amazing impact in the communities that we serve. Thank you very much.
I'm a fifth-year medical student and I'm the head of pediatrics. My feelings about this trip has been quite mixed. I was very apprehensive at first to see like 200, 300 kids, but it's been really overwhelming and wonderful. Currently we are a little inundated in our clinic at the moment. We've seen so many kids that desperately need our help and need dental referrals and also the OTs, so it's been very gratifying to see them and heartwarming. I think I made a lot of little best friends over the last 4 days. Yeah, so it's been a lot of fun, exhausting work, but definitely a lot of fun.
Hi, I'm Liam. The other day when we were speaking about it, I heard somebody describe this trip as something close to extreme sports, and although it's not exactly what it is and we haven't jumped off mountains, although we've come very close in this bus, it certainly is closer to that than hosting a clinic that we do every week. And I think despite the fact that we've been on buses for 8 hours at a time and had to convert every Google Maps estimate by a factor of 2.5, because bless her, she does well, but she takes her time in getting places, people have managed to maintain a sense of dignity for the patients that they're seeing. And I think that, coupled with the mentorship and fellowship that people have been having in the evenings and during the days, with a couple of tears here and there about the fact that food isn't ready on time, or we don't have enough food, or I left the vegan mince in a ditch on the side of a road, everybody managed to rally, as I said, and have a fantastic time and serve hundreds and hundreds of people who were left with a smile on their face knowing that they were listened to.
For me, this trip was phenomenal.
For me, this trip was fruitful.
For me, the trip was exhilarating.
I found this experience enriching.
Invigorating. Miraculous.
Eye-opening.
Challenging.
Enriching.
Unbelievable.
Unifying.
Worth it.
Self-discovery. Life-changing.
Eye-opener.
For me, the trip was empowering.
Exceptional.
Humbling.
Priceless.
Fabulous. Necessary.
Real.
Eye-opening. Enriching.
Wild.
Unforgettable.
Rewarding.
Inspirational. Radical.
Eye-opening.
Fulfilling.
Amazing. Inspiring.
Enriching.
Insightful.
Experiential.
Worthwhile.
Fulfilling.
Humbling. Important.
Spectacular.
For me, this trip was tiring.
skip through that.
So I think that was just the best way that we could show you what our 750 kilometer trip was all about. And just more onto what we do every day. So these are some of our projects that are new projects that we've started this year, aside from the trip. So in addition to this idea of this huge 75th anniversary event that we went on, we also decided that this year would be about getting back to what SHAWCO is really about, which is serving communities which are underserved. And so for us that meant looking at our clinic sites critically and saying which ones of them are really working and making a difference, and which ones where the environment has really changed and we should be moving our clinic sites elsewhere. So 3 new sites that we've started this year is our Hamburg clinic, another clinic in Imizamayetu in addition to our PEDS clinic, and then a clinic in Weinberg. And this is just really to increase the number of patients that we've been able to see. And a lot of these clinics focus on refugees or internally displaced peoples, and we felt that was something really important to carry out. And then in addition to that, we've also noticed in searching for new clinic sites that there are so many other places that are really in need of a service like SHAWCO. So that is something that is maybe an idea, is to have more sort of pop-up clinics in areas where we don't have existing SHAWCO clinics. Another really exciting project was the women's health clinics, and that started by a previous president of SHAWCO at the end of 2016. And this year we've been able to have monthly women's health clinics, and those offer pap smears and other health services, and they really cater to a refugee population in partnership with the Scalabrini Centre. So we're planning to have an Implanon rollout, which, as you've seen, started on our 750 kilometer trip and will continue with these women's health clinics. So another thing that we do is student development. So this is more for our students, and we run talks and workshops which aim to upskill our students, but also focus on mental health or other aspects of their own lives.
Yeah, student development is one of our other major sectors besides our clinics operation. And it's one of the main ways in which preclinical students and even some clinical students engage with SHAWCO and content that we are creating. It helps students to feel more competent when they do go out on our clinics. It equips them with skills for their own exams, things like mock OSCEs that we do, peer-to-peer training and education, teaching first years to do blood pressures, glucose screening, etc. And it's also a source of student bonding and builds a sense of camaraderie amongst the SHAWCO team.
So a new incentive system that we started this year, because we rely so heavily on student volunteers to run our clinics, we started an incentive program primarily to encourage clinical year students who may be a little bit busier to attend clinics, so they can get their little card signed off once they attend a clinic, and then there are little prizes like an ice cream or something at the end of a certain number of clinics.
One of the big drives this year, and in fact last year as well, was to take SHAWCO's data capturing system and make it digital, make it more sustainable and viable into the future. So through the tireless work of our SHAWCO research team, towards the end of last year, we launched at the beginning of this year our SHAWCO digital database. It's based off the RedCap web application, and it means that we are able to log patient data in person on a digital system. So this is one of the tablets that we use on our clinics. Students are able to log data. I'll pass around some images from in the instruction manuals to show what the drop-down menus look like. But basically it allows for adaptable data logging. We can include any fields that we think are relevant and any aspects of history taken that we think are relevant. It captures patient demographic details, patient comorbidities, and also one of the most important things, it allows for us to search patients who have previously attended SHAWCO, much in the same way as if you were to go to Grooteskier Hospital, you could look up previous patient blood tests, etc. So it allows for follow-up, and as far as we are aware, it's one of the first of its kind being piloted in a primary healthcare setting. Also, it has full UCT health HREC approval, meaning that the data that we collect with consent from the patients can be used for publishing of SHAWCO research, and will, over the course of a few years, generate a database that can be used. Research and publications, as I've said, is a new portfolio. In addition to what they've been doing in the digital data capture system, they've been working with special study module and public health students coming through the medical degrees to allow them to do studies specifically focused on SHAWCO. One of the big studies that was done a couple of years ago was done by Dr. Gordon, who is one of SHAWCO's big supporters in the faculty, who conducted a study as part of her master's just to assess the benefit of student-run clinics to students, as well as student appreciation and views towards this. And we could, of course, share the research with you, but the results were really positive and do show that we are running a model that is providing benefit not just to patients. This year we had an exciting collaboration with a team from UCLA who are running their own version of a mobile student-run clinic in California, and wanted to collaborate with us to find out what SHAWCO is doing that they can learn from, just to compare the two different systems. And so that is some exciting research. Health and rehabilitation was another one of our portfolios that we inducted the heads of this year. Previously, there was just a head of health and rehabilitation sitting on the SHAWCO steering committee, but this year we inducted heads for OT, speech and language, pathology, audiology, and physiotherapy onto the steering committee. SHAWCO remains one of the very few places on campus where multidisciplinary work is encouraged and where students are able to practice the information that they learn through their course. Our pediatric clinics are a great example of this. They continue to be a hub of all different divisions, offering a full screening service to kids, as well as the industry joining in. We do also have specialized H&R clinics. Sada Clinic and Fulani Clinic has now changed to Cheshire Home Clinic, and there's some new projects in the work. We've been engaging with the first year Becoming a Health Professional course, and we'll be enrolling a group of first year students onto SHAWCO clinics later this year. So looking back is one of the things that we think is important to do. Obviously, it's SHAWCO's 75th anniversary, and we think it's an important milestone to assess, are we remaining relevant to the communities that we're serving? And we have to be very critical about this, so that we can best direct ourselves into the future and remain sustainable. So what makes us unique, and what is our history? And those are some of the questions that have been driving us this year. So with that in mind, SHAWCO launched a SHAWCO Museum exhibit in partnership with the South African Jewish Museum, which will be running until the end of September and is free to all UCT staff and students on production of your student or staff cards. It will be coming to campus in October, and we'll then rotate it around some of the local museums just to make sure that everyone can get a good sense of SHAWCO's ties to the communities. There's some really interesting stories there. This is just an image, some of the photos from the trip, from the museum exhibit. The next thing is, and this was the vision that Ben and I had last year, was just to think, this has been 75 years, how do we make SHAWCO last into the next 75 years? And we believe that there's a number of things that make our model unique, have allowed it to be sustainable over such a long time, and continue to make us relevant. So one of those is, of course, student leadership. This is one of the very rare examples of a student-led organization that has such a large capacity, particularly in the healthcare field. Students are able to innovate. For example, the 750-kilometer trip, all of these other projects that we've been talking about are all student-driven innovations. And students have a lot of autonomy on the ground. The other thing which is most important for us is to be community-based. So all of our interventions would mean nothing if we sort of directed them without having a community person that we are engaging with. And so all of our requests for new sites, all of our innovations are driven by requests from the community. We build strong relationships there. The other thing is the idea of volunteerism as a resource. We all have a lot of free time that we don't necessarily know what to do with, or we have time that we want to give with. So by providing an easy access point for students, we are tapping into quite a large resource in terms of student hours, student expertise, and just hands on the ground. Task shifting is something that's very relevant at the moment, and it just means that we can't, in our healthcare system in a developing country, we can't necessarily rely on only specialized services at a tertiary level hospital to treat all the patients in need. And I think this ties in with the primary healthcare approach, which is to focus on getting out into communities in ways that can reach the most people in a very accessible approach. So this is what we do. We by having students partner with medical supervisors, we amplify the number of patients they are able to see in a given night. We also amplify the spreading of knowledge and information among students. Experiential learning is an obvious one. Medical graduates at UCT and across the country are always looked at positively because of their ability to engage in a practical way with patients. Seeing patients as a skill, providing rehabilitation services as a skill, even interviewing patients as a skill, and so it's something that you have to work on throughout your years, and we believe that people who come through the SHAWCO model are more competent and more confident in this regard. And then lastly, it's just a space to innovate. So the future, this is something that we have lots of plans in the work. We could talk for hours about ideas that we do have. SHAWCO has come far, and we think that it's got places to go. One of the projects that we are looking at is to see if we can help establish SHAWCO-like organizations at other universities across the country. This is something that's been tried before. We have actually engaged over the past few years with a few different organizations who've asked us for information, asked us for support, and just any sort of consulted us almost on what is needed and how to approach establishing a student-run clinic. And that's something that we think should be encouraged in the future. And it's really getting the SHAWCO name out there. I don't think that there is a reason that there shouldn't be a student-led outreach organization at every institute of higher education, particularly on the continent. So that's the end of our presentation, our brief presentation. Everyone's welcome to ask some questions. As part of our 75th anniversary, we are running a donation drive towards SHAWCO, encouraging people to donate denominations of 7.5 Rand, 75 Rand, 750 Rand, as high as you are willing to go, just to keep us doing the work that we're doing. And please do check out our social media handles. Thank you.
Wow, great questions. An incredible gift that you're giving to so many communities at so many levels, and also building the student capacity. So I think this is a huge celebration of primary healthcare and showing up. So it's a wonderful way of starting our seminar series as we look at all these themes of primary healthcare and violence and moving on to different areas of practice. And thank you for getting us. I think if we think of Prof. Moyosi's legacy, this is surely the area that we'd be really excited about to see what has grown and what has developed in this time. So thank you for getting our seminar series moving, and we trust that we're going to be able to extend this by passing it on through electronic media. Thanks.
Thank you.
Thank you.
Thank you, Karen.